So I am so delighted that we've got the opportunity to talk about Aspire and the fantastic work that AHPs have done through Aspire. So this film really tries to capture most of the improvement work, but of course it couldn't possibly capture it all. So Aspire is a strategy that we pulled together in 2017, and the aim of it really was to give us a focus for improvement work. So for AHPs, for allied health professionals, to be able to demonstrate the contribution they make to overall patient care. And really what we're trying to do is we're saying you do a fantastic job, but actually there's always room for improvement. And the whole purpose really was for people to look at the strategy and be able to look at what they do and challenge themselves to see if they could do better. So in Aspire we've got 4 categories. We've got transforming services, we've got digital solutions, and that includes kind of how we measure our impact. We've got developing our workforce and care assurance.
We developed a physical activity programme within physiotherapy, and that includes Pedal Forth, which is a cycling project, but it isn't just about going cycling. We try and involve people with the whole process of taking responsibility for maintaining the bikes, looking at routes, planning, also give them opportunity to do training in cycle maintenance. They go off and do accredited cycle leader courses, and then over time we get them involved in helping other people that are new into the group, becoming peer supporters. Further down the line we give them opportunities to further train, and they become NHS Forth Valley mental health volunteers, and it's a role that has been, for me, extremely rewarding. It's one of the most rewarding projects that I've done within my whole career, and to see people who've been through the whole cycle of mental illness coming out the other side and then giving back and helping others is just fabulous.
As AHPs, we recognise the value of using a quality improvement approach in planning and developing our services. This year we're delighted that 14 AHPs have completed our local Learning for Improvement programme, developing their skills, their knowledge and their confidence in using QI methodology. We've recently taken an opportunity to review the AHP mental health input within mental health and learning disability services. By using a QI approach, we aim to maximise the success of our impacts in these areas, optimising the quality of care patients are receiving while supporting staff in their own developments and enjoyment at work.
So I was honoured last year to be awarded with the OBE for services to dietetics and public health, and really that work was working with the Scottish Government, with the prison service, and created food policies for them. And in fact that's linked with some of the work some of the girls are doing in Forth Valley. Wendy Hanley, who recently won one of the Scottish Health Awards for her work with prisoners looking at food and giving them skills. And I guess my love and the real direction is about enabling people and enabling others to help people make positive, healthy life choices. So I think one of the really important things and roles for AHPs is our ability to support early intervention and prevention to avoid needing unnecessary treatments in the long term. AHPs are very much part of that, and I think over the next few years we'll build on the amazing work that we've done to date.
Went into Corton Vale, linked in with the nursing team there, who helped us establish where we were going to do the scope, and we went from there.
We started off just half a day a week, clinical work, just to see, actually to meet the prisoners and see what we felt their needs were, and it's led to some opportunities in terms of the forensic network. We've got involved with that. We've presented at the conference. Yep. So that's, again, it's been a steep learning curve from us. We went from actually just being quite novice to it to putting ourselves into these, and we presented at the NHS Scotland event as well. So
what we've done throughout the whole project is ensure it's sustainable. So we've never taken on anything that we've not looked at being able to sustain it. So it feels like we've done it in a very systematic way and just continued to build, and it's been evidence-based.
And that was a steep learning curve as well,
huge.
wasn't it? Going into prison for the first time, and there are different systems to learn and different training and things that we had to do at first, and it takes time, I suppose, to get to know the prison way of doing things when you're so used to working in health. But
we've identified a massive clinical need and also a role that we have as mental health OTs. We have that specialist skill to make a difference and impact.
We are now working in 28 out of 54 GP practices throughout NHS Forth Valley across 5 clusters. This equates to 17 members of staff, and we can now offer approximately 600 to 700 appointments per week within primary care physiotherapy. We have developed QI strategies, so we have implemented clinical networks for injection therapy, for radiology, and we are currently running advanced physio practitioner training days along with GP engagement days, so they have a better understanding of the role of physios within primary care. Statistics as of December showed that over 80% of patients seen by my primary care physio team are now managed solely within primary care without the need for onward referral.
I had picked up this document, Prehabilitation for People with Cancer, and it's a great document looking at prehabilitation, which is really just starting the rehabilitation journey much earlier. The length of stay in hospital can be shortened. It can improve their exercise, their respiratory function, their cardiac function. It can also improve their nutritional status, quality of life, all of this. And it's all about empowering the patient to do that as well. When I did the questionnaire, the people who were very active and ate well, did lots of exercise, just sailed through their treatments. They were well through their treatment and recovered well. Because when a patient has cancer, everything just lands on them, or the process is there and they have no control over it. But by doing these things, they actually have ownership of their treatment and how they get through it.
So over the last 18 months, we have been part of the Best in Class project, which is a project designed to help people with lower limb arthritis particularly, and try and manage it better, because we're very aware that we used to not do things very well, or there was a lot of variation in what we did. So now there's advanced practice physios in GP surgeries, and we're seeing people very quickly rather than sitting on waiting lists for long periods of time. And we're giving people access to information sessions on a monthly basis so they can learn about their arthritis. We're giving them access to classes in local gyms and school halls. We've seen drops in referral rates to orthopaedics and to physiotherapy. So the orthopaedic referral rate for knee and hip problems over the age of 45 dropped to about 18%, and for physio dropped to about 12%. But there was a swing there because everyone else's referral rate went up, whereas ours went down, so actually it was about a 27% change. So we're seeing big changes in how people are managing their joint problems, and it's just with information, with guidance, and with good exercise.
We had waiting times for breast patients coming to see us. It was about 6 to 8 weeks that they were having to come if they had found any problems. When I came, I started doing ultrasound and biopsies, just pretty much the same as what a consultant radiologist did. Just finished doing breast MRI reporting as well, which is the first in Scotland, the first radiographer in Scotland that's done that. Biopsies we have to do academic, we have to go on a course to do that, and that's a full year academic course. That would normally or historically have been a consultant radiologist that would do that. But we can now do that. You can either do it under ultrasound guidance or you can do it stereotactically, so we can use the mammogram machine. So I do that as well now. And we're moving on. Our next step is to do vacuum assisted excisions, which means that the patients won't have to go to theatre anymore to get benign things removed. So they'll avoid having a general anaesthetic. It's better recovery time. Surgeons won't be involved in that anymore. They'll just come in here and get it done and be away. So it'll be a lot cheaper and a lot quicker for patients, and not so much, so they won't have to take time off work so much. They just come in and get it done in the one day, which was great.
Ready Steady Steps, so it's a physio-led movement group. We're working with a targeted group of children. So we're working with children who have delay in their walking skills, but we hope that they are going to achieve independent walking. We're working on standing balance, we're really working on developing strength, stepping skills. So this group of children, we're hoping that by the end of the block, the parents will have really improved their confidence and competence and really how to work with their child. A lot of them will hopefully be then moving on to discharge. Creating an environment where it's fun, it's friendly, it feels nurturing, so that everyone feels happy in the environment, supported. Just having a variety of fun activities for the children to try, so that it's not a set programme that they have to go through everything, but it's really being guided by the child so that they can go to where they want to go. And the whole idea is we're finding what the child is motivated by to achieve what we're wanting to achieve from a physio point of view.
For me, coming into post, the biggest thing for me tackling was the variation in wait times. So the wait times were set at 23 weeks, which for me were not good enough. I had difficult conversations with staff about why that was. We then took the brave decision to change our triage process. The referrals were all triaged centrally at Stirling Community Hospital, and we looked at our capacity demand across the service. We've now got our wait times down to 4 to 5 weeks, which is a huge improvement. It's improved better outcomes for patients. Patients are being seen by the right person at the right place at the right time. We've also reduced our DNA rate. We have now reduced that down to 5% because we have got patients to opt in for their appointments. So again, it's a cost-saving exercise, but it's also improving the better outcomes for the patient, which it's all about.
We redesigned the AHP Rehab Care Group single point of referral for the community-based rehabilitation teams. I did some process mapping and found out what we did have, how we could change it, how we could streamline it, and therefore come up with something that was going to fit the need of all of the teams, plus create the team of the single point. So where it was very much beforehand, what are you struggling with? What can we do to fix your problem? Now we're asking open questions more about what do you feel the issue is and how do you feel we may be able to help you? We had 6,250 referrals in a year into single point of referral. 73% of them went to intervention at the community teams, with 18% of them being diverted away from the community teams after receiving signposting, reassurance, advice and education. So at that point, 18% of these people that we'd had referrals for didn't need AHP input at that time.
The use of digital technology is crucial for the transformation of the NHS, and it is really important to have clinicians helping to lead and drive the digital and e-health agenda. Through Aspire, we are transforming AHP services through the use of technology. We are rolling out the use of dashboards so services have ownership of their data and they can understand why we're recording what we do. We've recently implemented a new electronic patient record system called Morse. This is being used by many AHP services and lots of nursing services. This is really exciting times for us because this, for the first time, is going to bring us a mobile solution for electronic records. This is going to make such a difference because no longer will staff need to come back to base to record their records. A really successful piece of work that I was involved with was the development of a renal dietetic database, which I did in conjunction with Caroline Ritchie. This was so successful, it freed up patient-facing time by 20 hours per month. We could see how through the use of desktop software, so for example Microsoft Excel, was able to free up time through a lot of automation of processes, for instance. That work was recognised and Caroline and I received the British Dietetic Association Dame Barbara Clayton Award. It really helped put Forth Valley on the map. I could not do that work if it wasn't for all the services, the AHPs, the staff, the management, but of course the e-health department here as well, who are so supportive of the work that I am doing.
I decided to combine my two interests of renal and digital technology to create a renal dietetic online module. Staff can access this module at a time that's suitable to them. The module is interactive. It uses games and quizzes to engage the user. We've had lots of positive feedback on the module. It's evaluated really well. Lots of people saying it's fun. Lots of other health boards across Scotland have expressed an interest in using this module. So a lot of staff might not be aware of phosphate and potassium restrictions and the different foods that patients have to limit. It helps the information to sink in when they're moving the food across themselves. So now if a renal student nurse wants to spend time with a dietitian, we advise that they look at this Learn Pro module first, and then they can come and spend some face-to-face time with the dietitian while we're speaking to patients. But it gives them some background knowledge, so they're a bit more prepared when they come along to spend time with the dietitian. They're more aware of our role in speaking with the renal patient.
It is a specialist diet where we look at the undigestible carbohydrates in our diet. The same person could come back and forwards and see you 20 times in clinic, and you probably never really ever made any real difference. It's reduced the amount of unnecessary colonoscopies, having repeat tests done. I can see it myself quite often. The person's been seen by the gastroenterologist 2 or 3 times before they send them to me. It's a very tech-enabled thing as well. The apps are probably the best asset we have, because apps can be updated very quickly. It's a modern treatment process. I've trained with another dietitian. Between us, we've trained 60 dietitians in Scotland in FODMAPs. You know, I wanted my dietitians to walk away from that with cooking, recipe, adaptation skills, menu skills. I mean, we train dietitians as well to look at menus and packets and tweak a recipe and take all the FODMAPs out and put something else back in, because that's at the end of the day what your patient needs. The apps only tell you what you can and can't eat. They don't really take you through the process or teach you how to actually adapt what you're already doing to make it FODMAP suitable. So if your dietitian can take the time to do that with you, then again, it's far more patient-centred, it's more realistic, and the person's actually going to be able to achieve it.
I was one of the first dietitians to do supplementary prescribing, and that's why it's quite a big thing for dietetics. Implementing supplementary prescribing has been a challenge personally, academically and corporately. It was a huge undertaking, but it has been well worth it. The future will involve developing evidence of good prescribing practice, and it's an exciting time for dietetics. It certainly raises the profile and will not only enhance patient care, but hopefully ease pressures on clinicians. For me personally, supplementary prescribing enables me to work in conjunction with pharmacists to take clinical and legal responsibility, for example, in parental nutrition that we are prescribing, instead of asking junior doctors who have no idea what parental nutrition is. And this will save doctors time and improves patient safety.
As part of a test of change, the speech therapists and dietitians looked at putting in place earlier screening within the acute admissions and clinical assessment units. This was aimed at increasing earlier intervention for nutrition and hydration management, ultimately hoping to reduce the length of stay for patients. By ensuring people with suspected swallowing difficulties are identified earlier, patients are not unnecessarily kept nil by mouth, and they will have quicker access to appropriate levels of diet and fluids. And by identifying patients who are at nutritional risk earlier, we can help reduce the measurable adverse effects this will have on function and clinical outcome. Malnourished patients who attend hospital are likely to endure more complications, longer recovery periods, and more support required on discharge from hospital. Our goal is to improve and support patient experience and journey. This is definitely for both of us.
Yeah, absolutely, and just as well we've picked them up early.
Allied health professions have had a real focus in the past year or two on digital solutions. Speech and language therapy in particular were very early adopters of the use of Attend Anywhere or Near Me, which has allowed us to move a lot of our face-to-face meetings to be virtual meetings. This has had a great impact for us because it's reduced the amount of time and money spent on travel, and it's freed up staff capacity to do more clinical work. Near Me meetings have become the norm for lots and lots of us. So in speech and language therapy, we've been piloting using Near Me increasingly for some of our clinical work. We haven't used it with anyone as their only form of assessment or therapy, but we're beginning to use it frequently to augment face-to-face therapy, and we've had really good feedback from our service users. Because they're not spending time and becoming stressed, travelling and trying to get parked and using up all of their energy, then they have much more stamina for some of the clinical work that we're doing with them.
We've been working on improving the healthy culture for the last 18 months. We had individual conversations with all the staff members. It was a very simple conversation where they were asked a couple of things, which was what makes for a good day at work and what makes for a bad day. and we really properly listened to all of that. And I noticed the culture shift as soon as we started listening. And you need to be brave as a leader when you're listening to that, because some of the stuff's hard, of course it is. Key to the improvement was that we had an improvement group across banding, and whilst it was initiated by the leaders, it was driven by the staff group, and they had absolute ownership of this. So they framed it in quality improvement methodology, they looked at the data, and they decided what the priorities were, constantly working with the wider staff group. When you look at the research and you look at what we've done in regards to transforming our service, we've just undergone a huge transformational review, and the output of that will be that we meet the needs of the most vulnerable people in our society, and that's what we're really motivated. The staff are totally up for it. I think the research suggests this as well. You've got because we've managed to shift the culture and get all those things in place, it's made this change so much more effective. I think what's important to me and what actually motivates me to come to work is knowing the staff want to be here and that they enjoy coming to work and they're making a difference. That's the really key thing, and I've really prioritised that, and I think we're seeing the fruits of that in terms of staff retention and actually making real differences for the people that we're working with in Forth Valley.